this one just press from one side. Okay. Okay, thank you for your kind introduction. I think I have left UM for the past, this is going to be my third year in private practice actually. Currently I'm based at KPJ Ampang Puteri. Okay. Let's begin the presentation. Okay, blood cancer is an umbrella term for cancers that affect bone, that affect blood, bone marrow, and lymphatic system. So, unfortunately, okay, blood cancer affects a large number of people, but maybe it's like underdiagnosed. But now with all the advancement in the medical diagnosis, we're getting more and more cases. So, every 20 minutes, someone in UK told they have blood cancer. That's around 70 people a day, around 25,000 people a year. And the data may increasing by now. So I think I'm just going to go through briefly, tracing the timeline, a journey through history of blood cancer. So I think this is a summary diagram, okay? So with the discovery of the circulatory system, microscope, and then later with all this radiotherapy, chemotherapy, we're moving towards near in the early 2000s with the advancement of all this molecular profiling. Okay, and which later, I think, now I think the aim is regarding precision medicine, so we can minimize the side effect of treatment. And the latest, very popular now, right now, everyone is talking about the CAR T-cell therapy. This is the latest advancement, yeah. So blood cancer is very broad, but this is a top three blood cancer. Lymphoma is the highest, followed by leukemia and also multiple myeloma. Okay. So lymphoma, as I told you before, is the highest, is 1 in 2 blood cancer cases. It develops in the lymphocyte, and when there's an abnormal proliferation and it will turn up into the lymphoma cell, followed by leukemia and multiple myeloma. Okay. In general, lymphoma, the most common in non-Hodgkin, followed by Hodgkin lymphoma. In general, leukemia for acute lymphoblastic leukemia is more common in pediatrics, and acute myeloid leukemia more common in adult. Okay, multiple myeloma used to be a disease in elderly. Usually, we got referred from orthopedic patient presented with a back pain, low back pain, and then eventually to diagnose with multiple myeloma. But now, we see much younger cases as early as 30 and 40 years old. Okay, presenting with a very aggressive multiple myeloma presentation. Okay, so this is a summary, okay, of leukemia. So it's a cancer of our white blood count. So we divide into 2, acute and chronic. Acute 2, acute lymphoblastic leukemia, acute myeloid leukemia, followed by chronic lymphocytic leukemia, and chronic myeloid leukemia. As you can see, the presentation whatever the presentation the patient come to us depends where, because it's leukemia, so abnormal proliferation in our blood factory. So let's say if it affects the platelet, patient presented with bleeding, bruising, and petechiae. If affected the production of hemoglobin, patient will present with anemia symptoms. And other presentation is like bone pain, gum swelling, scrotal swelling. Okay. So I think the gold standard diagnosis until now, we don't, even everyone is talking about the fluid biopsy and so on to minimize the pain to diagnose, but until now, we see the gold standard is still a bone marrow examination, okay? Okay, so this is the summary that I told you before, acute and chronic, and then it's quite simple to follow. Acute lymphoblastic leukemia, acute myeloid leukemia, and chronic is a chronic lymphocytic leukemia, chronic myeloid leukemia. Okay, the diagnosis, a gold standard is a bone marrow. Nowadays, bone marrow is not like something scary procedure. Most in government setting, we do this as an outpatient procedure, unless in a certain high-risk cases, okay? So after a bone marrow examination, from the bone marrow aspiration, we send a lot of investigation, not just aspirate and refine. We proceeded with all this molecular testing and also cytogenetic. Okay, like for example in leukemia, the way we risk stratify the patient is based whether it's a low risk, intermediate risk, and high risk. So it will change a lot. Like say if patient with low risk acute myeloid leukemia, we just can give chemotherapy and not need to subject patient for stem cell transplant. But let's say if we send all these results and then they have all the high risk markers, for example FLT3 mutation and so on, that is when we need to work up for stem cell transplantation. Okay. So treatment management, just in summary, usually depends on the disease factor and patient factor. So it depends on what type of cancer, what type of leukemia. And patient factors, of course, we need to, different patient, different, not everyone similar treatment. Let's say if we have elderly leukemia, so treatment totally different. Let's say we have a leukemia transformed from myelofibrosis, so it's totally different and so on, okay? So I think this is the most top one cancer for blood cancer, lymphoma. So we're getting more and more cases. So I think now many patients walk into my clinic and then everyone blame on the vaccine. Yeah, most of them think the whatever the leukemia and lymphoma because of the recent vaccine. Okay. So in general, we divide lymphoma is very easy, whether it's Hodgkin or non-Hodgkin. Okay, Hodgkin, we have the subtypes, and non-Hodgkin, in general, we divide into B or T. Most common is B cell. Okay, there's more than 60 subtypes of B cell and a T. In general, the highest for B cell lymphoma is the most aggressive, that is diffuse large B cell lymphoma. And B cell, just in general rules, usually is better outcome than T. T usually, even we give patient chemo, or even if they're already in complete remission, usually associated with more poorer prognosis. So we eventually subject the patient for a stem cell transplant. Okay. So to remember, what are the symptoms of lymphoma? So depends where the lymphoma arises. Usually they have a non-specific, all the B symptoms, fever, loss of weight, loss of appetite. So we will ask patients, is it intention or unintention? So nowadays a lot of youngsters taking a lot of products just to lose weight. So that one is by intention losing weight. So it's just suddenly they lost weight. It's something alarming sign, okay? Drenching night sweats. But currently I have a few presentations. They have no lumps, nothing, except for, like recently I have one of my staff walk into my clinic, Dr. Adila, I think something not right with myself. I lost 10 kilos within 2 weeks. Because she is one of our PET scan staff, so I told her, maybe we just do your thyroid function, no lump and bumps, full blood count, everything normal, blood, everything normal. So all the tumor markers normal. So I say we do a thyroid. If your thyroid function, you are hyperthyroid, we stop there. So I refer you to endocrine. But if not, we just proceed with PET scan. So to cut it short, she diagnosed with a stage 4 non-Hodgkin lymphoma. Okay, just completed her chemotherapy. And unfortunately, I think a few months after that, when her PET scan showed complete remission, her husband walked into my clinic with low back pain and diagnosed with aggressive multiple myeloma. So currently, both of them receiving treatment next to each other at our daycare. Okay. So I think what are the data from Asia? It's very, very lot of data. This is when I was still based in the University of Malaya. This is from the unpublished data. So we want to know what's the data from Malaysia, because the last data more than 10 decades ago actually, just published around 25 patients of a lymphoma. So I think our common type is still non-Hodgkin lymphoma compared to Hodgkin lymphoma. And the highest among the B is still diffuse large B-cell lymphoma. Okay. Staging, I think, is quite a standard staging, and both classification. If localized, one area is stage 1, involvement 2 lymph nodes on the same side of the diaphragm is stage 2, and of course, if disseminated elsewhere, is stage 4. Okay, you see here, diagnosis is still gold standard excisional lymph node biopsy. So we have a lot of patients wrongly diagnosed. Maybe they just had a FNAC, or they just had a true cut biopsy. So it leading to a lot of false positive. Okay, so one of my ex-anesthesiologists walked into my clinic crying during the COVID time. She's in charge of COVID ICU. So she has all this non-suspect fever, all this thing, and all the fear of COVID. Suddenly, husband is a surgeon, did a true cut biopsy and diagnosed with T-cell lymphoma. Okay. So I told the husband, can you please repeat the biopsy? So she almost quit her journey of becoming an anesthesiology specialist just because of that. So after we revised analysis with proper true cut, actually it's just a kikuchi. So it's non-cancer. So that's what I'm trying to tell you is very, very crucial to get a proper excisional biopsy. If true cut, let's say if you cut the lymph node at the T area, you diagnose with T-cell lymphoma. B-cell lymphoma, unless in certain very challenging cases, like all the lymph node inside, near the artery, near the vessel, bleeding, low platelet, that is other scenario. Okay. So treatment lymphoma, chemo, immunotherapy, stem cell transplant, and of course nowadays everyone talking about minimize the side effect and getting the cure for the cancer. Okay. So multiple myeloma, I think is very popular, especially for medical students. During our medical school, everyone put this CRAB, C-R-A-B, okay? So usually patient presented with hypercalcemia symptoms, anemia symptoms, or recurring infection, bone pain, or pathological fracture, okay? So I think this is the one that I told you. I'll move on. So you can see there's a lot of treatment for multiple myeloma, and there's a lot of new treatment option nowadays, okay? So I'm not going to, this is the data I presented during the ESCO. So you can see now they're moving towards really MRD remission, so unlikely detectable of the cancer cell, as the ongoing clinical trial. Okay, you can see the involvement of CAR-T, BiTE therapy, and so on. Okay, treatment highlights. I'm going to talk a bit about chronic myeloid leukemia. Why? Because this is all the targeted therapy. Actually, this is the, the starter of all targeted therapy start from this chronic myeloid leukemia. If you read through the article, it's based on IRIS trial with the development of tyrosine kinase inhibitor. With the very first, later there's a boom of other targeted therapy treatment in any other cancer. Okay, so you can see it's disease of first by many aspects. Okay. I'm just going to skip that, okay? So you can see with all these things, with the targeted therapy movement, now the survival is increasing a lot to 92%, right? They live normally. And you see the era before this, with the interferon, the survival is not that great. Now it's just achieved almost very good survival. So you can see it used to be incurable, curable for some, long-term disease, now treatment-free. We can even stop the treatment. Okay, they just take medication like a diabetic patient, and eventually when they're really in good remission for 2 years, we can stop the treatment. So I'm just going to move. I would like to add contribution by researchers and clinicians in hematological. That is a hematopoietic stem cell transplant. It has evolved from being experimented in 1950 to a standard care for many malignant and non-malignant hemato diseases, okay? So just a brief, hematopoietic stem cell, they are found in the bone marrow. They have a property of cell renewal and able to differentiate to all cell lines. Okay, so this is a nuclear bombing in World War II, inspired research into radiation effect in bone marrow, leading to major breakthrough in bone marrow transplant. So Dr. E. Donner in 1956 received a Nobel Prize in nuclear medicine after the transplant from a twin donor in the leukemia cases. So we have two types of transplant, autologous and allogeneic stem cell transplant. Autologous is from your own stem cell, and allogeneic is from other stem cell. This is services of the stem cell transplant, just big here and there pictures at KPG Ampang Putri. So a few indication. Okay, I'm not going to go through it. Okay, the challenges, there's always challenges. I mean, the main challenges actually is to get the donor. Let's say even you have 10 siblings, based on study, you only can, our HLA match numbers is just around 25 to 35%. So we need to get like a half match or maybe a match unrelated donor from overseas. So that is time consuming. So this is actually a very short video. I would love to share if there's a time. This is a true story, based on true story. The challenge of getting stem cell transplant is not easy, especially in patient needing, in a certain case, like a leukemia cases. Huh?
Yay! Congratulations. Oh.
I'll get a match.
Okay. Don't mess up my desk.
I already got a match.
You are a smarty pants. Thank you. And I am gonna get a picture. I know. Okay. Okay. 1, 2. Oh, it's Dr. Fisk. Just hold on.
Brenda?
Howdy! We are having our big celebration here. We got cake.
You get a dog bone.
Brenda, listen.
Here,
Fine.
hang on.
I'll eat it by myself. No.
No goofing around with that knife. Okay, doctor, I'm sorry.
I've got some tough news. The donors backed out.
No. No, they can't. They agreed.
But this happens more than you think. Maybe they'll change their mind, but we should start looking for another match.
But it took years to find this one.
We don't have a choice. Come by my office tomorrow. We'll talk through Taylor's options. Don't say anything to her just yet. A lot can change in a day.
Okay, so I think this is just a very brief hematopoietic transplant evolution in Malaysia. Okay, you can read through that. This is a study conducted what's our data in Malaysia. So our supportive care is very good. So our data is comparable to other developing country overseas. Okay. So now I think we have a lot of things, a major breakthrough that receive a lot of novel like immunotherapy, for example, like with rituximab, immune checkpoint inhibitor. Okay. Now CAR-T. CAR-T basically is our stem cell is modified and then programmed into, and then we introduce back to our body to kill targeted against the cancer cell. Okay, this is something, the latest advancement in our blood cancer. So research and collaboration, is very, very important. Yeah. So supportive care and survivorship. I just would like to move to this young girl. She went through a lot of journey. She failed multiple lines, more than 7 lines of chemotherapy. I have no choice. Before I get another new targeted therapy come over to Malaysia with all the import permit process, I transplanted her with a disease of progression. During that time, she has a lymphoma involvement, everywhere. How to move? Okay. She would love to share her cancer journey. Yeah.
About my cancer journey. I was diagnosed with non-Hodgkin lymphoma cancer when I was 26 years old, and that's back on November 21. Back then, doctor told me I was stage 2, so I was kind of comforted because we could detect at early stage. How unfortunate, by the time I completed my radiotherapy and 6 cycles of chemotherapy, I reached stage 4. That's when we had to resize the treatment plans and rebiopsy. Without realizing, life kind of steered me to get a jump off the dream. I still remember the days I was introduced to the second line chemotherapy, and it was very intense for me. I remember the ICU days, neutropenic, anemia, infection and sepsis days. I had a few chemo regimes, and then the most pricey one, but none could present a good score yet. Still, alhamdulillah, I managed to keep my stem cells in October last year. But then, just recently I got lucky to utilize it for the stem cell transplants. And finally, the scores is now showing me. Alhamdulillah. The journey full of ups and downs. I don't know how many times to survive, how I could reach this far. But all I can say is I'm proud of myself for surviving through the days I thought I couldn't. I know it's all due to Allah's decree, alhamdulillah, but I also know I won't make it this far without the grit and just I have today. My family, friends, not to forget doctors, nurses and the staffs. Thank you. Thank you very much.
Okay, in conclusion, the field of blood cancer treatment is rapidly evolving, offering new hope and possibilities, early detection, innovative treatments, comprehensive supportive care, and collaborative efforts. We are advancing towards a brighter future in the fight against blood cancer. So I think please continue to raise awareness, support research, and stand by as we work together to conquer this disease, okay? So I think I would like to just end my presentation with thank you for listening. Yeah?
Thank you, Dr. Adila. Any questions from the floor? Okay, Dr. Adila. Yeah.
Thank you for the great presentation. Just wanted to ask about the use of CAR T cells. So currently, has it been implemented in any hospitals in Malaysia? And if it does, how is the success rate?
Okay,
Just wanted to
so
know.
I think, like for example, CAR T, yes, it's available in Malaysia, especially in your Islamic Medical Center, doing it very well. I think under Dr. Chang. I have not started the CAR T yet at KBJ Ampang. is doing a HUKM. There's a clinical trial. So like if patient don't have money or what refractory, you can refer to them. If they're eligible for trial, we recruit them. So the success rate, I would say, in general, the is not that really great, because when a CAR T patient referred to us, usually they already like a refractory, in very refractory cases. So the CAR T that we gotten to all this modify is not a great quality already. So of course the risk is higher, but there's a hope in that. So now I think the latest research people talking about upfront CAR T rather than referring in a high risk profile disease, rather than at the end, the last option in treatment. Yeah.
I have a question from someone that was a bit scared to speak on the mic.
Yeah, no problem.
Recently, I have a friend of mine who died from leukemia. He was only 20. And a lot of my friends are quite shocked by this. And they wanted to know exactly how to be aware of when to get a diagnosis, because bone marrow to be taken is quite an invasive process. Something like colorectal cancer also to get checkup is quite,
Okay.
So they were wondering when should they be looking into this exactly?
Okay, I think there's no, of course, I think I have one family tree. The grandfather died of lymphoma. The mother walked into my clinic and diagnosed with non-Hodgkin lymphoma, and recently brought his son from UK, just back from with low platelet. So, okay, based on study, in comparing a normal population that have no family history of cancer, so with someone that have a strong family of cancer, of course, your risk is higher. Okay, but what causing this cancer? Because most of leukemia are de novo, it's just suddenly. I'm not sure, because our nowadays lifestyle and so on. Okay, there's no way, because but acute myeloid leukemia usually presented very acutely. So sometimes just accidental finding just with a high white cell count. They don't have any other fever, swelling, and like lymph node swelling, bruising, and so on.
He died really suddenly.
Yes, suddenly. And I got one patient just cry in my clinic when I was in last time. She said, Dr. Adila, how can you say I have acute myeloid leukemia? Last week I just went for a full body checkup and everything was normal. That's why we call it acute. It just suddenly come out. Okay. So I think if I always told patient, if you think something not right, just come early. Okay, and then meet a clinician, meet a doctor, so that we can do necessary investigation, not necessarily a bone marrow. Okay, we won't start, when we see patient, not say, you must do a bone marrow. It is depending case to case basis. Like elderly, sometimes they're already presented with high white cell count. I think by doing bone marrow, sometimes we think won't change any management. So sometimes if the count is enough to flow, so we proceed with flow cytometry to know whether it's acute myeloid or acute lympho and so on. Yeah, that one just by blood taking. Yeah.
Do you believe every year should be taking this?
No.
Right? Okay.
Thank you for the question, Prof. Leong.
Yeah, thank you. Yeah, I have a question. So I'm just wondering, with the advance of all the molecular diagnostic, right? How do you see the role of this NGS or even like MSAT in terms of early detection of lymphoma and also treatment? What is the role?
I think, of course, we can risk stratify patient nicely, okay, prognosticate them nicely, and then like I mentioned before, so we don't unnecessarily subject everyone for stem cell, because it's very toxic, and then the mortality, treatment-related mortality is there. So with this advancement, and now there's a lot of development of targeted therapy, so I think we can narrow down our treatment and so on, so less toxicity for patient. Okay, we can pre-plan. But I think not easy, even in private nowadays, I think to get insurance clearance for all these molecular NGS, it's not easy, I tell you. And then per panel, it can be very expensive, like a 7 to 8K. Yeah. You half of it, you run the lab, yeah, maybe I should meet you after this. Yeah.
Thank you, Prof. Leong. Any other questions? Okay, Dr. Adila, I have a question for
Yes,
you.
yes.
So, as you have shared, most patients actually present with very vague symptoms,
Yes, yes.
such as back pain. So, if they go to a general practitioner, what would they do? Usually, they just treat the symptom, right?
Yes,
So,
very true.
yeah, as you said, it's acute. So, a matter of 7 days, it becomes an AML. So, what is your take-home message for young doctors or primary care practitioners to have or facilitate a high index of suspicion?
Okay. I used to teach medical student last time, so I would say history, and physical examination is very, very important. Okay, it's just like same with pediatric. When mother bring the child to the emergency, please don't ignore them because mother know what's the best. Their instinct is always right. Okay, don't send back the child home. Okay, it's the same thing. If the patient says something not right, doctor even do a blood test, everything normal. Please, I think have more. How to say, empathy, high index of suspicion so that we can diagnose early. A lot of my multiple myeloma actually presented very late to me with the advance of a spinal cord compression, cannot walk. They went through to GP, back pain, all given analgesia, or they presented with acute renal impairment because of the NSAID. Or they went to see a lot of orthopedics, but no one really clicked is a multiple myeloma. So for me to raise the awareness is very important. I'm not sure if doing the talk, I'm sure that's what NCCM been doing right now, yeah. Just to educate, keep on educate the public, yeah.
Thank you, Doctor.